Hi, thank you. This is Dr. Lokesh. This topic is about family medicine, post-graduation in USA, UK, and India. And it's honor to present this information. Um, I like to share my presentations. Um, Let me share the screen. So, family medicine, USA, UK, and India. My request is every family in India under the care of family medicine postgraduate is essential. It is also advised by the World Health Organization, and also they are recommending a modular training, Middle Eastern regional office WHO for the last couple of years. So this is essentially, it's not just increasing the PG seats, but every family in India under the care of family medicine postgraduates is essential. So that's what my request. And here is the definition of family medicine postgraduate. Many people say MBBS alone, doctor can alone be um, family medicine, but the WHO definition is multidisciplinary team practice is different healthcare services provided by family physician postgraduate multidisciplinary team that are characterized by comprehensive, continuous, coordinated, collaborative, personal, family, and community-oriented services. So for these to serve, they need to have at least 3 years of extra clinical experience. And this approach, people receive continual health promotion, disease prevention, diagnosis, treatment, disease management, rehabilitation, palliative. It's very complicated work. That's the reason they recommended post-graduation training, more clinical experience. I like to thank India has expanded many colleges. It's first thing in the world. This many colleges for last 10 years. Will thank central government funding 70 to 90% of the new medical colleges. In numbers, the Honorable Minister J.P. Nadda ji sir given statement in February. I'm sorry, September 2024, a month ago. The increase of the number of medical colleges. From 2013, 387 till almost 766. And also we thank India current government increasing MBBS seats from 51,000 to 1 lakh 15,000 by 2024 this year. And in USA, if we compare them, there are 39,000 PG seats, 4 times is 120,000. So we're pretty much equal as a population basis, USA 4 times the providing the physicians. And PG cells also went up to 73,000. But India, we thank India vision of creating equal number of PG seats. In USA, actually 130%. We should be able to reach that, but at least we can able to have one seats, one MBBS. And that means need to go to 115,000. And health ministry policy is one PG seats, and this also mentioned, and we'll thank you for that vision. And Indian is 20% PG seats in family medicine. I will explain a little more. And USA has 130% PG seats. People like me who got into that 30% came. And the solution, one of the solution is family medicine up to 25-30%. We thank for mandatory department. India has amazing concept and nowhere in the world. If you look at the mandatory department in MBBS, we have almost I think 20 mandatory department. Of course, many colleges in the world they have these anatomy, physiology, biochemistry, paraclinical, and clinical medicine, surgery, OBGYN. In USA, they have emergency medicine core and also family medicine. But these branches like dermatology, radiology, ENT, and otolaryngology, ophthalmology, orthopedics, chest, anesthesia, radiation therapy, radiation, and they're even before 1980. This is the best model in the world because when you're creating not only the medical college, you are creating these many specialties in a district level. That's the model which is amazing. It's only in India, nowhere in the world. In other countries should able to take look at this model. And of course, we have gaps of emergency medicine and family medicine, and of medical oncology and neonatology, which I'm going to go more into the family medicine in this presentation. What is the benefit of mandatory department? Medical college department produce need of workforce. So if you want any workforce without the mandatory department, you cannot increase the workforce. And for example, all the specialties, the highest number of PG seats are because are mandatory. Job creation in medical college and services in that area. And these are the departments which we need more. And power of government is amazing. You can able to administer a policy change which can affect the whole country. And also we need a continue of ownership. I will mention about one issue. So coming back to the family medicine, this is the 0.36 family physician postgraduates per 1 lakh population. In USA is 31, UK is 81, and Australia is 141, and Canada is also up there. So actually debate is not up to 31, debate is between why the gap. Australian model is more like our India, which is a remote area, they are big country, and UK is mostly almost urbanized or semi-urbanized. So I think we need to look at these models, why they are going more family medicine because the remote and rural areas need of coverage. And New Zealand is looking more of the Australian model and Canadian model, increasing there from 70 to I think up more level. Did this family medicine need is recognized yesterday or health ministry recognized before? Health ministry already recognized in 2002, and there's a document in MCI, Ministry of Health and Family Welfare recommended 2002 at least 25% of postgraduate seats should be in family medicine. Then no new postgrad should be started in any medical unless this condition is fulfilled. So they already your department already know, but somehow it did not implemented. Could be because of maybe ministry could have recommended a mandatory family medicine department at that time. Then the workforce could be at least 3 to 4% now. So that's the one thing I think we're recommending, suggesting, and also there's other reasons I will mention in the presentation. Is WHO recommend how many percentage? Now we're looking into the, what number of the family medicine seats. Of course, World Health Center, like 0.3 for work for 10,000 actually, it's not 100,000. Workforce for 0.3 for 10,000. And USA has sorry. And USA, I mentioned in the picture before, WHO is 30 per 100,000. And strengthening the primary healthcare through family practice model. And they have done this Eastern Mediterranean region. So they recommend 30 per 1 lakh population. So you have different countries which are recommending 20 to 30%, even up to 40%. And this is the information on the WHO. So we recommend a task force by ministry of how many specialists India needs it, how many special general surgeons needed, how many specialist medicine, OBGYN, pediatrics. Then that way you can distribute. We thank ministry, government. You restricted 100 seats per 10 lakh population. So at least there's some number. It could be debated a little bit up and down. But that kind of policy we need in specialty. How many ophthalmologists we need? And in USA, there is every organization, association will put out their numbers every few years. That is followed. So we need government to make this committee. I will explain this slide a little bit closer. And because of the mandatory, and there is some specialists are more productive, some are less. So I took this per 100,000 population because at that time I did this slide. Our MBBS seats are 100,000. If we have 100,000, pathology we have almost 2,961, whereas in America, USA only 600. But their percent is 1.6. India is 2.9. But now with the new medical college, some will go up. It will go up to 3-4%. So it's definitely more percent per 100,000. It's so radiation therapy we have mandated department. I think this number is also much higher. This 0.5 is wrong. Radiation therapy is also much higher because US 200 is over 5 times higher. In dermatology, US 507, we're up to 1,400. So we're much, much higher, 14% of the 100,000. Here also 1.1 for radiation therapy and zero point 0.5 for the USA. These are numbers are reversed. But ENT, look at the ENT. We for 18,000 seats already exist. But if you're new medical, it will be more than America. And specialty ophthalmology, 2.7% more than 1.3% from America. Orthopedics is a mandatory department. So we have 3,000 seats compared to 899 in USA. And it will grow with the new colleges. And surgery itself, we have 5,200 compared to America has 4.4. OBGYN, we have 5.2%, where 5,200, whereas OBGYN in USA is only 1,500, but 44%. Anesthesia, look at 6,000 versus the 19, but population-wise, they have 5% of them. So all these specialists, which are because of mandatory clinical, and we have PG seats created, our 22% of the PG seats are this specialty, but India already have 30%, even it will grow more. So I'm going to present next slide. What we're behind compared to the family medicine. USA is actually not a great model. They still have 13%. We have 20 to 30%, but Canada up to 40%. So how many seats we have? America have 5,000. India has 6,000. So we need much more, maybe 20, 30,000. General medicine. India, America has 27%, they have 10,000, we have 6,000. It need to grow, but there is a models depends on how much percent of general medicine, family medicine, that's separate topic to research and present to you. Psychiatry itself, America has much higher than India, so that's needed more. Emergency medicine, we just started, and we requested, I think 3 years ago, Vinod Pal sir said in a meeting in Tamil Nadu and made it mandatory, and that's why at least some seats are went up, but we need mandate emergency department back again. That's my humble request. So it still needs 7,000 more. So this is the percentage, pediatrics is a little bit more. So this is where we need, and India need a policy. That's why we need a task force or committees to every few years, what percentage need approximately for each states also we need to follow. How to create 25,000 or 30,000? First of all, the NMC mandate family medicine. We need to know medical college or district level. We have to show that, and then that they may create one ward, 30 bed, may have at least 5 seats. It may create 3,800, but we need much more. India has the greatest infrastructure. 1,000 government hospitals, 1,000 bed, 100-bed hospital, and there are 6,000 community health centers. Each one has 30 to 50 beds. I just spoke to a doctor who treats snake bites very well. Out of 100 snake bites, 0 deaths. Compared to USA has only 10 deaths per year. But so coming back to them, and they mentioned that this cluster, these together, we can create 10 seats, and that means 1,000 beds, 10,000 seats. Private hospital, I don't know exact number, but 100 bed, 200, there's so many. But you need to create more, mainly family medicine, general medicine, but not other specialty. They are enough. That's what my presentation. And I'm talking to one of the senior official, said the anesthesia may come and want more, or other branches may want, but your policy, what percentages you need to Indian needs. So if you create another private sector, another 10 to 10,000, so there is a lot more number we can create. So 20 to 40,000 depends on need. Let's go back to the training of the UK. We want to go to UK. Okay, great. We want to learn MRC GP. We have a degree. Oh, MRC GP is a great degree. And what do? They have 3 years training like India. 1 year in the hospital inpatient, 2 years in the outpatient. See, outpatient clinic, they see maybe 10 patients a day. And if you look at the Indian Community Health Center, as I spoke just now, Assam, where the community health 30-bed hospital, they have 20 patients, they see 200 to 300 patients a day. And see how much exposure clinical experience. So that clinic can see so many patients. India has more patients than PG students in USA and UK. And most of learning in PG course is from patients. We learn from patients. Of course, theory knowledge is there. We have technology-wise, we can deliver. And we have NBME, we have Thailand, we have meeting with ILCOR, International Liaison Committee. We're honored to have NBME representation by Dr. Subodh Kumar sir. And when he visited a long time ago, University of Maryland, they said, oh, we have 6,000 trauma patients. but Ames Delhi has 60,000 patients. So remember how much experience we have. So I just want to mention India has more patients. We can create more PG seats, and that's the greatest gift you can give to every family in the country to have family medicine postgraduate under their care. About USA, USA also, remember USA medical colleges, 25% don't have hospitals. They they train first 2 years, then they go to small hospitals, get the rotations. So student has rotated to private hospital and private doctor's office. Family medicine is a 3 years training program in USA, and 50% is outpatient, 50% inpatient. So we have so much outpatients, inpatient. That model we can able to create in a workforce. University, Western Michigan, where I work, and the director said for each CHC, 50 bed can be given 4 PG seats. Imagine 6,000 times 24,000. So we have CHCs, we have 100 bed area hospital, we have private clinics, and we have volume. And also Dr. Vinod Spalsar said, when he presented a meeting in API or the Zoom during COVID time, he said every bed in the country need to be used for medical education. So this is the program director, Dr. Christy Vanderklok, and I met her and I presented the information, what I have seen, talked to a few community hospitals. These are deliveries, outpatients, 200, cesarean section. We have general medicine doctors, surgeon, OB, pediatrics. And she said, we can have at least every CHG can have 3 to 4 PG seats a year. Nodal center. We wanted my request is no 100-bed hospital could be a nodal center and CHGs could be subnodal centers. So that way you can able nodal have a program director or HOD can able to in charge of it. And we can create each nodal center, 10 of them, that itself give 10,000 or more. This is most important. You must need e-learning platform with lectures and exam. This is most important we need, because we need to have exam which is equal to USA and America, and our exam should be located the same way. We are still with the essay and short questions, but we have to move on. In USA, they moved on 1956 to all multiple choice. And e-learning, you can have lectures there, you can have self-exam there, self-assessment, and once a month or twice a year, you can go to the proctored examination. So district hospital are not available anymore because they all went to medical colleges. And, and you can also say one nodal center in the medical college and connect with all other things. That model can be done too. Postgraduates are essential for all medical colleges. Without PGs, can we run medical colleges? Definitely not. They are very essential. Why not we give the same PG seats in 100-bed and community hospital? Imagine how their health will be improved. So by I mentioned already, Dr. V.K. Palsar said all government private beds should be used for medical education. So by presencing a postgraduate 24/7, any emergencies can be taken, they can learn, and then quality of that rural area, remote area will be much higher. Like I said, the doctor who saved 200, I'm sorry, 1,200 snake bites, only zero death. If you have PG available there 24/7, when they come, as soon as they can able to immediately emergency treatment can be done, and overall health care of acute care will be in 100, 200% will be much will be better. E-learning platform, transfer of knowledge is high. Compare, you can do the examination. We can compare the examination when the UK people, other people come, and oh, this exam is like us. Okay, excellent. India, one state, doctors can go to other states. In UK, most of the MRCP doctors, now they are going to Australia with the same exam. They don't have any more exams. India, like our state, one state doctor can go other states like that. Our one Indian degree, why can't they go to the other one? And I work with the NBMEC, is now is a part of association, International Medical Rating Board Association. NMC board also approved, they're planning to apply. So this kind of association will help us to be in parallel with the world. And they're looking for India to take the lead in road in Asia and in world. So e-learning platform is must. So I now took the NMC leadership in the last December. Federal State Medical Board, National Board of MEA of America came, and their members came and had a meeting with NMC, and so that they can talk each other their issues. And NBME also, they visited their office, and Dr. Ajit Sir came to the NBME. I took them to the NBME of USA, where they do all the examination for the last 100+ years. So this is the e-learning platform where the students can know what they are scoring, or how many they are correct, how many they can compare. And the program director, every college can compare, or one program other, and BME has more role and exam. So that's very, very important. So mandatory department, why we should do investment? I have 6 causes. One of them is, of course, we're going to provide health, family medication, medicine postgraduate to every family in India. Health Minister policy is 1 PGC to 1 MBBS, which will fulfill. NMC Gadget says, which I'm going to mention next slide, mandatory family medicine department. And if you look at the America, core subject is family medicine, which is not missing in India. And of course, workforce numbers and ministry also recommended this I mentioned before. So to fulfill the NMC, even the because it has strength, it keeps coming back again and again. In this NMC gadget, it says these are the things: develop competency-based curriculum, addressing the need of primary health services, community medicine, and family medicine. Number 25J, promote, facilitate postgraduate course. We still have 7 hospitals out of 700 plus hospital have family medicine. The curriculum of primary medicine, community medicine like US and other models, they need to have it. You have to have mandatory. It's not. It's very easy. If already faculty is there. It's not difficult. This should have been done 3-4 years ago or 20 years ago, as recommended by your Ministry of Health. So this is a screenshot of where the USA have different course of clinical subject, and here you see the pediatric, OB, general medicine. In family medicine, you have 3 modules. So that's what we need. I want to mention what the America doing versus us. Universal healthcare. In every country want to universal healthcare. Without the captain, family medicine postgraduate is a captain for the universal healthcare. If you look at any other developed countries, especially European models are more successful, Australia, Canada, and they have family medicine graduate is a core person. Why not MBBS? MBBS clinical experience is very small. And I requested one of the medical college in Andhra Pradesh called NRI Medical College. They started the family medicine and they have a primary health center. When the MBBS doctor goes there, they see only 5 to 6 patients. But if a family medicine doctor graduate, when they're 25 patients. So patients want, consumer wants higher. When patients' family want to be seen in the postgraduates. No lifelong experience. MBBS doesn't have their own association, so they don't have lifelong experience. And nurses in, I talked to one of the family medicine doctor, asked him, I talked to the nurse told doctor, MBA, a family medicine graduate is like a multi-specialty doctor. They see the pediatric, they see the OBGYN, they see the everyone. So that's important. And medical license in countries like USA, UK, they're giving only after 2-3 years of post-graduation. They're not giving any more post people. So UK GDP is important. UK model is better, 10% GDP, versus USA is too much, 17. That model is not going to be workable for us. Cost of postgraduate. I like to mention postgraduate cost. $12 billion they spend for PGs in America. That means 1 lakh crores. It's a big budget. And 50 in India, 54% PG seats are private, and 46% are government, and a few percent is for central government because of the aims. So this much money is the what US is spending. ECFMG president requested they have. I'm 64 years old. Doctors in America, 60 years old, so 30% of them, they're worried about their workforce will be crumbled. So they want to look at how many Indian PG seats, postgraduate training. I told them 3 years comparison is equal, but they want to look at the examination, how they conduct, or the but our PGs are very, 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 very well trained, but they are looking for us to look into the workforce. If Japan can send their cars all over the world, why can't our resources, doctors can, healthcare workers can go other, but still we have 90% still in India, but even 5% can spend to the other part of the world. And they're looking for alternative pathway to give medical license to other country physicians. So medical education revenue, I want to mention this, the examination, nursing examination, internal examinations, the exit examination. I'm not talking about entrance exam. Itself has so many associations. That itself is a topic. They raise almost 4,000 crores in USA, but we have 4 times more 4 times more students. And This one I already mentioned, and this is what we propose for making family medicine mandatory department. Every 100-bed private hospital have PG seats or 50-bed cluster. Government funding it to the nodal office. If you can fund the program director, and that will be great. Creating DNB center in all government area hospital. E-platform, very essential. Exit exam, similar to SUK. All PhDs eventually, this is a 20 years program. By 2047, if you have enough family medicine as MBBS doctor slowly retired, it will workforce fills up. And all DMHs could be family medicine postgraduates. And the same thing I'm recommending private bed hospitals. They take Arugusri, so government has influence on them. Um, 50 bed is more than enough actually when you compare to the UK. So we want to look into that model because 30% of them are 60% are outpatient, so they can be a role model. Private med should start family medicine. Of course, if you make it mandatory, that will be good. And we already said, and WHO is already recommending it. Provide every family the care of the family medicine. I mentioned this, and these are some other articles. And we need the unity, I mean, NBME, NMC, and private colleges, and all this one electron e-platform, and continuous for the betterment of Indian healthcare. And this one I already mentioned. If you have 100 MBBS, you can do the 10C, PGCs in NMC, and then they can create other model. And we thank you. We like to make in India medical education could be as a resource to help everybody across the world. And emergency medicine also department, please create, bring back emergency medicine mandatory department immediately. If it is workforce issue, at least you produce all colleges which are there in the existence at least 6 years after, so it doesn't affect the pressure on the young hospitals, won't put on the burden. Thank you.